is Dr. Jeff Berger, and we have Dr. Scollon-Grieve, and we'll be talking to you about non-surgical treatment options for back pain. Sorry about the delay in getting on board here. We had some minor technical issues, which I think we've worked out. So by way of background, so my name's Jeff Berger. I'm a physiatrist. I practice physical medicine and rehabilitation. I specialize in orthopedic, interventional orthopedics. And so the majority of patients that I treat come in with back pain, neck pain, radiating pain into the arms of the legs. And so both Dr. Scollon-Grieve and I really work hard to exhaust all the conservative treatment options, trying to help patients avoid surgery when they can, and when they need surgery, properly directing them. So, Kelly, I'm not sure.
So my name is Kelly Scollon-Grieve, and Dr. Berger and I are the same specialty, and we have the same type of practice. We see the same types of patients, and we both are working in our Wayne office, which we recently opened about a month before COVID-19 hit us. And I also practice out of the Havertown office, and Dr. Berger has been out of the Ford office. So thanks for joining us. I was having technical difficulties. I can't see myself or Dr. Berger, so hopefully everything looks okay.
We can see you well. You're nice and centered in the image, so it looks good.
I won't move.
So I guess, so our plan today was hopefully just kind of give you an overview of, how we manage back pain, and particularly now with COVID-19 and how we're handling things. The way that we look at back pain and treatment options, the way that we'll typically run patients through options. Also, hopefully, be able to provide you with some tips that you can be using right now while you're at home and socially distancing, and then hopefully offering you guys plenty of time to ask some questions. And so typically, the patient comes in our office, and or we talk with them via the computer, via telemedicine, which has been more and more. I'll say that probably at this point, majority of patients were initially evaluating via the computer or cell phone, and we're able to actually pretty effectively triage them and get a sense of what's going on and at least next steps. And so, typically when I'm talking to someone about their back pain, there are a lot of different factors. Number one is it back pain, or is it pain that's radiating down the legs? And so, pain that's radiating down the legs we call neuropathic pain, and generally. And so neuropathic pain means that it's nerve related, whereas back pain is more often mechanical in nature, meaning it's not directly related to a pinched nerve in the back or sciatica, but symptoms that are more localized to the back. Sometimes that pain can radiate. Sometimes it can radiate into the buttock or into the upper thigh area, but it's not typically nerve related. Nerve type symptoms being numbness, tingling, or in other cases even weakness. And so many times when a patient comes in, that's one of the first questions that we have. Other questions are, what makes it better? What makes it worse? Do you do better when you're at rest, when you're sitting versus standing? How do you feel when you're walking? Sleep, does it interrupt with your sleep? And then most importantly, how does it interfere with your overall activities of daily living? How does it affect the things that you love to do in life? And what can't you do as a result of that? And so I will say that we're seeing, both Dr. Scollon-Grieve and I have been seeing, a lot more back pain given COVID-19. And, the question is what's causing that? Why are we seeing it? I'm seeing a lot more disc herniations now more than ever. I'm sure Dr. Scollon-Grieve can share her thoughts. I think that a lot of it, though, is related to a lot of sort of sedentary behavior, us being out of our normal exercise habits, not doing things we typically do, sitting in front of a computer just like I am right now, hunched over, leaning forward, and that's certainly going to put more stress on our discs and put them in a position where they're going to be more liable to herniate. And then similarly, I know I don't want to speak for everyone else, but I know I'm doing a lot more sort of household activities and home projects, and a lot of things that my body may not be used to doing, and so putting myself at risk with that. So yeah, back pain persists and has probably been a lot worse in spite of everything going on. So.
Yeah, I've certainly been seeing a lot of people increased back pain from sitting and vacuuming and constantly cleaning and, working parents that are normally working out of the house that are home with the children and doing a lot more lifting and activities with them, just different than their usual, certainly aggravating.
Yeah, so and it does make it difficult because not only so typically like when we're talking to patients in the office and we're talking about various diagnostic tests, be it an X-ray or an MRI or maybe getting you started in some physical therapy or osteopathic treatment or chiropractic treatments or injections. We're going through risks and benefits, and that's just the nature of medicine. We're always talking about the risk benefit equation and what's going to be in your best interest both in the short term and the long term. And so now we're in a situation where we're not only talking to patients about, well, what are the risks of let's say an injection or a procedure. It's also what are the risks or potential risks of you leaving your house or coming into the office. And so I'm sure we'll talk about it a little bit more later, but we've tried to create an environment in our office where we are minimizing those risks, in every way that we possibly can. In terms of, when patients are coming in, we have a virtual waiting room now. So patients are instructed to wait in their car until we're ready for them. They're calling or texting when they arrive. As soon as we're ready and the room opens, we're reaching out to them and they're, have direct access right back to their procedure room. When they come in, we're fever checking them. We're going through a questionnaire, of course, for COVID-like symptoms. And then they're coming right back into the room. Of course, we're social distancing, wiping all of our surfaces. Everyone is in a mask. We're doing our procedures or in evaluations, and literally as soon as you are done, you are going right back to your car and potentially doing a short recovery in your car if that's needed, or going directly home. But it's all about just reducing exposure and reducing contact. So I don't know, Dr. Scollon-Grieve,
Should we talk a little bit about different causes of back pain?
Yeah.
So for me, I feel like a lot of patients will complain that they have sciatica. And, basically that's a term for pain radiating down the leg, which can be caused for many different reasons. The main cause would be a disc herniation, which we've been seeing more and more of, which the herniation is pressing on the nerve and then causing that neuropathic pain that Dr. Berger was talking about down the leg. Sciatica could be caused by arthritis in the spine, causing spinal stenosis, which is irritating the nerve. Some people get sciatica from their sacroiliac joint, which is the joint between the pelvis and the lower spine, and that could irritate the nerves going down the leg. So those are the main common causes of sciatica that we see a lot.
Yeah.
The other main source of pain that mainly stays in the back would be arthritis in the back, muscular imbalances, disc problems that aren't necessarily herniations, but degenerative discs can cause localized pain to the back around the waistline, not necessarily radiating, and that's very common in middle-aged people.
Yeah, and I think one of the challenges that we face treating back pain is sort of the root cause of it, and so the reality is that the spine is incredibly complex. In the lumbar spine, there are 5 levels, there are 5 discs, there are 10 paired joints, there are multiple ligaments, there are muscles, and the challenge is that the nerves, many times back pain can be difficult to localize, and so. Just based on a patient's symptoms or their age or their risk factors or their exams, sometimes it can be, hard to precisely say, well, this is, the structure that's causing your pain. And so, I know for me when I was in fellowship training, 12 years ago now, the whole focus was, well, finding that single pain generator and treating it. And I think over the years we recognize that now it's rare that there's just a single source of a patient's pain. For example, if you have a degenerative disc and you've lost some disc height, well, in turn, that loss of disc height is going to put more stress on the joints in your back. The stress on the joints in your back will cause joint-related pain along with disc-related pain. When you lose disc height, that puts you at more risk for developing some narrowing or spinal stenosis, which can cause some nerve irritation symptoms. When you develop nerve irritation, that can lead to higher level weakness in the glutes. And so there's a lot of, so it's pretty rare that it's actually just a single structure that's actually causing your pain. And, and I think that, Dr. Scollon-Grieve and I mean, we're big believers in sort of taking a step back and looking at the bigger picture and what are all the factors that are driving your pain. So.
Yeah, when patients come into the office and we evaluate them, we don't just look at the spine, we don't just look at your imaging, we evaluate the whole body, especially the joints above and below, the entire spine, the hips, the knees, the ankles, the feet, because everything starts from the feet up, and that can affect your spine and every other joint, muscle, tendon, ligament involved. So we have to make sure that we are very thorough and we fully evaluate every patient.
Yeah. Yeah, and so it's not even just, it's really putting together the symptoms and the exam and the imaging. And so, at the end of the day, I mean, we're big believers. We don't just treat the MRI or the X-ray. We treat the person because the reality is that 40% of 40-year-olds have some disc degeneration or some disc bulging even without any symptoms. So MRIs are incredibly sensitive, so you need to be cautious in terms of just focusing in on that MRI. The physical exam is a really big piece of the equation. So, all right. Well, looks like we're getting some questions coming in. Yeah, I'll read them off. Does burning of the sciatic nerve help with pain? So sciatica, is a description of symptoms and, meaning nerve pain radiating down the back of the thigh into the calf. And so there are a lot of different causes for sciatica. Sciatica can be due to a disc herniation that's pressing on a nerve. Sciatica could be due to some degenerative narrowing in your spine. Sciatica could be caused by muscle imbalances, piriformis syndrome, compression of the sciatic nerve in the buttock area, or sciatica could even be, referred pain, not even from a nerve itself. So the sciatic nerve itself is a large nerve that is formed by a number of nerve branches, smaller nerve branches coming off of your spine, and the sciatic nerve really controls the two-thirds of the muscles in your leg. So in terms of burning nerves and burning the sciatic nerve, that's not one that we would want to burn, because if we did, you'd be left with permanent weakness in the leg and a foot drop. There are certainly some procedures that involve burning nerves. Radiofrequency ablation is the term that we'll use, and so there are some small sensory nerves that we can deaden with a needle in your back. So this is most commonly used for pain that's coming from the joints, the facet joints in the spine. Where under an X-ray machine, if we properly localize the pain is coming from that joint, we can take a needle and numb you up very well, and then heat that needle up to create a thermal lesion in a very controlled way to deaden that joint so it no longer causes you pain. And so that would be a situation where burning a nerve could help with pain, but not typically the sciatic nerve. Yeah. You have any thoughts on that, Dr. Scollon-Grieve?
No, it's a question I get a lot when people ask me if I can just burn their sciatic nerve, and you gave a great explanation for that.
Yeah.
I can't any of the questions. So if there are any more, you can just read them.
Yeah, I'll read them. I'll absolutely read them off. Yeah. So I mean, and I will say, like, I agree. I mean, there are many patients that come in, I just burn the nerve, like cut my leg off if that's what it takes, and I hear that all the time with disc herniations, actually, especially like in younger individuals with a large disc herniation. I mean, they come in, they're going out of their mind with pain. Just cut my leg off. Do whatever you need to do. And obviously, we don't amputate legs for disc herniations, although that certainly may be one way of getting rid of the pain. But many times when it is a disc herniation, let's say that if we can get you through the short term, most patients will do well without surgery, and so at least 80% of patients will do good or excellent with conservative management of a disc herniation. And so many times that's a question of if the pain is really severe, we're talking about an injection as a first line treatment to try to get the symptoms better, to at least allow you to move better and get into physical therapy. From an injection standpoint, that could take the form of an epidural steroid injection, or it could take the form of a regenerative medicine treatment like a platelet lysate injection, which we're having some really good results with. So, okay, so next question. I've heard that steroids are bad for the joints. Are they bad for the back?
I'll take that one if you don't mind.
Yeah, of course.
So, yes, there have been studies published recently that confirm that corticosteroid injections into knee joints in particular are detrimental and can lead to more advanced arthritis earlier on. Same thing theoretically goes for injecting steroids in the back. There hasn't been any published research per se, but we know that injecting steroids into the muscles in the back can certainly cause atrophy over long term. We still do inject steroids in the spine, especially for epidurals, to help decrease the swelling and irritation around the nerves, and it is generally effective for a lot of people. However, the safer alternative would be to use your own body's products, such as your blood. So a procedure that I would prefer to perform on people would be to do a procedure where we take your blood and we process it in the lab and take out the platelets, and this is a special procedure called platelet lysate that's safe for the spine. We can inject your own blood platelets around the nerves and the joints. We inject it into the ligament and the muscles to help strengthen them, and that is a better long-term solution, ideally, especially for somebody younger or middle age that we don't want them to deteriorate over time. We also do the similar things for the joints, and would prefer to do that instead of injecting cortisone repeatedly in somebody's knee.
Yeah. So the more that even though it's interesting because even though steroids have been, been injected into joints for 50 plus years, the data is actually somewhat limited, and and even though these procedures are generally covered by insurance and very, very mainstream, the question really is how much good are they doing versus potential harm or damage. So I agree with Dr. Scollon-Grieve. I think like in a situation where patients come in with acute back pain due to a disc herniation, then yeah, of course, an epidural steroid injection is reasonable. If patients are getting significant or long-term relief, great, but it's not something that you want to be doing on a regular basis. It's kind of a means to an end, I think, in that get the pain under control, allow you to get into physical therapy, and allow your body to heal itself in the most natural way possible. So if you are going to be doing that epidural injection, we make it clear. I mean, it's a chemical treatment really for what is a structural issue. The epidural injection isn't going to fix the problem per se, but it is going to reduce your pain. And by doing so, hopefully, we put your body in the best position possible to heal itself. And then we can contrast that with a regenerative medicine procedure like a platelet lysate procedure, which is going to inject growth factors, which are associated with nerve healing and nerve regeneration. Okay, do disc herniations ever go away?
Do you want to do that? I don't think so.
You want to go for it?
Sure.
All right.
Yes, for the most part, disc herniations will go away. It could take 18 to 24 months in a lot of the studies that have been around for many years to reabsorb themselves. The disc will never go back into being normal, but the part that's herniated and pressing on the nerve just your body sends cells to the area that are like little Pac-Man cells that eat up that disc herniation that's pressing on or irritating the nerve. And that can take up to 2 years to do. But for the most part, most people, their body will do that and take care of it without necessarily needing to have surgery. And then kind of jumping into when would you need to have surgery for a disc herniation like that. If you have acute weakness in the leg, foot drop, something like that, where it's obvious that there's compression of the nerve, that's usually when surgery would be indicated. Or if it's a prolonged course where conservative treatment options such as physical therapy, acupuncture, epidural steroid injections, all of those other options are not helping and your pain is severe, then surgery would certainly be indicated.
Yeah, and I think, so many times it's a question, because we know, that, 18 to 24 months, 80% chance that this is going to improve and the body will be able to resorb that disc. We definitely try to avoid surgery, but obviously if you're with weakness or particularly progressive weakness, that's a different situation. So usually, if you have a disc herniation, we're having our patients monitor their strength. Walking on their tiptoes or walking on the heels is an easy way to do that, or doing some squats, just to make sure that weakness is not getting worse. But for pain alone, generally if we can ride it out in the short term, the studies say that at 2 years out, patients who elect for surgery and those who elect for non-operative treatment are in the same boat. So, what about topical creams for excruciating pain going down the legs? In my mind, I think the results for topical creams are very mixed. I will say that there is minimal risk to these creams, and that's the beauty of them is, particularly for our patients, who can't tolerate non-steroidal anti-inflammatories. And anti-inflammatories are bad. These are, we certainly prescribe them, but they can cause a lot of issues. And, millions of patients have GI bleeds or kidney problems as a result of these anti-inflammatories. So for those patients who are at high risk or can't take them, an anti-inflammatory topical cream, I think can be helpful. I see the best results in joints that are very superficial, though. So knee joints or hand joints for arthritis. I do think that anti-inflammatory creams can be helpful. In terms of anti-inflammatory creams for nerve pain, there definitely are some creams out there, compounded creams as well, and I think it's very mixed. I don't know what your experience has been, Dr. Scollon-Grieve, but for me, I'd say maybe 30% of patients do get relief with it. The challenge is that you do also need to apply it on a regular basis too, and at the end of the day, you're not really doing much other than masking symptoms and the underlying problem. So.
Yeah, I find that often it doesn't get deep enough, but it can help more with superficial pain. I think the patches are usually easier because you can stick it on and not have to reapply it 3 or 4 times a day. A lot of patients really swear by lidocaine patches, but again, insurances don't often cover them these days, and it can be very costly to actually apply this.
Yeah. Okay. I occasionally have a burning sensation in my thigh. That's really by rotating my foot medially. To what would you relate this sensation? So, so obviously it's tough to say just based on those sorts of symptoms. Just thinking about it in terms of rotating your foot medially, what's happening there? You're probably internally rotating your hip. The fact that makes it better, tough to say. Typically if it's hip pain, and so hip arthritis related pain is usually felt in the groin and the upper thigh. Usually that's actually worse when that hip joint is getting loaded and stressed, and so typically actually internally rotating the hip would actually worsen those symptoms as opposed to make it better. If it is a nerve injury or, which is what we typically, attribute burning pain to be, if that nerve is put on slack when you're internally rotating, maybe that would make it feel better. tough to say. I mean, there is a nerve that kind of radiates. There are several nerves. Obviously, it's by sensation to the groin area, ilioinguinal, iliohypogastric. More commonly is also the lateral femoral cutaneous nerve. And so, it's possible that by internally rotating your leg or your hip, that's maybe taking some of the stress or pressure off of the nerve. But that's a tough one. I don't know. I mean, that would be definitely a physical exam and probably a diagnostic ultrasound, which we'll generally do in the office. So. Okay. What about a chiropractor? Will a chiropractor help me with pain?
I am, generally not against chiropractors at all. I think a lot of people are helped by them. It just depends on how comfortable you are. Some chiropractors are more aggressive with a lot of cracking. Some are very gentle and don't crack and do more myofascial release and soft tissue work with very gentle manipulations. Usually I say it's worth trying if you're open to it. However, it's better to have a diagnosis. Some chiropractors are good at evaluating patients, but I would certainly recommend coming in to see a physician, a DO or an MD, to fully evaluate you, see if there's any imaging that's needed before doing that option. Or if you've been seeing a chiropractor for a while and you're still not feeling better, that would be the time to reach out to a DO or an MD. We also have osteopathic physicians, which are DOs, do manipulations, which we have some in our practice that are excellent, and we always recommend patients do them as well.
Yeah, I agree. I mean, along those lines, I mean, I really embrace chiropractors. I think they can, they can really help us a lot and certainly help, with the right issues. I think that when you're dealing with, some mechanical joint issues or alignment issues, muscle issues, I think chiropractors and hands-on techniques can be really good. Many chiropractors specialize in some specific muscle techniques as well, which can be helpful for tendonitis. So, I think when you're treating back pain, it's sort of an all hands on deck approach, in that it's rarely is it just one specialty that's going to get you better or optimize your results. So, rarely is it just the surgeon alone, and certainly just the surgeon, or just the physical therapist, or just the interventional orthopedic specialist like us. I don't think, pretty darn rare that Dr. Scollon-Grieve and I will see a patient, and just say do an injection on them and then send them on their way. It's going to be, if it is an injection or procedure, it's that followed by maybe some osteopathic treatment, or preceded by osteopathic treatment or chiropractic work or physical therapy. So, what about pain stimulators? So spinal cord stimulation, peripheral nerve stimulation has been around for a long time. The technology's gotten a lot better. Really in the past 5 years, just like cell phone technology has come a long way, battery technology. There is absolutely a role for spinal cord stimulation. And I still do a fair amount of work with that. I think less so now, and now that I've got other options in regenerative medicine. I mean, it's always preferential. If you can fix a problem, we like to fix it. But there are some issues that cannot be fixed, unfortunately. I mean, if you've had let's say you've had back surgery before, and a fusion, and you have scar tissue that's built up around the nerve. Unfortunately, the options are really limited, certainly from an injection standpoint, and physical therapy and manual therapy can all be really tough as well. And so those are patients where I do think about spinal cord stimulation. For the right patient, can work very well. And now with newer sort of high frequency stimulation, 80% of patients are getting relief of their back pain and doing well. But it's got to be the right patient, and I would say in our case, it's less than 1% of all the patients that come through that we're recommending or even talking to about spinal cord stimulation. So, what do you recommend for people who need to sit all day for work?
I'll take that one. So I always recommend trying to get up as much as possible. Try to set your watch for every 30 minutes to get up, or at least reset your posture, roll your shoulders back and down. some adjustable standing desks are great. I know a lot of my patients have them in their office when they were going to the office, but now that people are working from home, they might not have that at home. So if you can try to rig something using books or boxes to adjust your desk or your laptop or computer at home to a higher level so you can stand for a little bit, that would be great. Other things that you could consider are you can buy an adjustable standing desk that you just put on top of your current desk. It's not the whole thing. That's a few $100s, so it's a cost, but that does work very well. And I also, myself, I prefer to sit on an exercise ball or a ball chair so that you can try to make yourself a better posture by that, because if you don't have good posture, you might fall off. So that can help strengthen your core and your glutes, and you can kind of get a little core workout in while you're working, and that works for me to alleviate my back pain when I'm sitting a lot, which is what we're doing now with all the telemedicine we've been doing.
Yeah, I can attest Dr. Scollon-Grieve does have a sit-to-stand desk set up, and I do as well, actually, thanks to her influence. So it's a good idea. I mean, the longer that you sit, as you sit, disc pressure builds up. So particularly people with degenerative discs, they have a really hard time sitting. That's one of the first questions I ask when we're evaluating back pain is how long can you sit for? If your sitting tolerance is 5 minutes or less, there's a very high chance that you've got a degenerative disc or perhaps a tear in the disc. And so the longer you sit, the more that pressure builds up. So, jobs where you can transition from, a seated to a standing position are ideal. And if you're stuck in front of a computer, being able to go from use a sit to stand desk up is really good. Okay. Is there any correlation between taking statins and muscle tension or muscle pain in the back? I think it's questionable. I mean, certainly statins can cause pain. They can cause muscle pain. Usually, that patients experience a lot of thigh pain or buttock pain or sort of proximal muscle issues when it's statin related. There is some blood work that can be done that, unfortunately, those is not overly sensitive to pick up statin related myopathy is what it's called. There's some nerve testing that can be done as well, but generally it's a trial of coming off of that statin for a month. Obviously consulting with your cardiologist or the prescribing physician and seeing if there's an improvement. There's at least one study that I'm aware of. It was a large study looking at over 5,000 patients, looking at correlation between statins and back pain. And I think that they did find that there was a correlation, but the challenge is that that there may be some inherent bias because, the way that the study was designed, the patients on statins had other medical issues as well and likely were more sedentary and as a result were probably at greater risk for back pain to begin with. So not the best study. So. Okay. Are there any other treatments other than shots and surgery for back pain? You want to take that?
Sure. So certainly a lot of other treatments, I think we touched on a lot of them, but generally we try to start least invasive first. So depending on your pain level, if you can tolerate doing physical therapy, chiropractics, acupuncture, osteopathic manipulation, home exercise and stretching program, or some oral medications, that would be the first step. Second step would be shots, a lot of different types of shots that we talked about. Shots using steroids, we talked about the potential risks of that. Then there's the shots using your own blood or bone marrow products, which would be more ideal for most people to help stimulate healing. And then obviously the last resort is surgery. We try to avoid getting cut open, but in some cases it's unavoidable, but we always try everything before that.
Yeah. Okay. How can you stand straight without having pain, starting to get hunched over? Um, so we talk a lot, obviously, about posture, sit to stand desk setups, walking, and so the one of the challenges is that you do see a lot of patients who are people in general who are very sort of hunched over, and they've got that sort of forward flexed walking pattern, and so there are a lot of different sources for that. Most common would be spinal stenosis. So spinal stenosis is just a fancy word for narrowing. And so spinal stenosis, narrowing in the spine. When your spine is flexed, it tends to open up the spinal canal, and it gives those nerves more breathing room. So patients with spinal stenosis will characteristically have that bent over walking pattern and have a really hard time straightening up. The problem is that when you've been doing that for years and years, and it's very natural. Your brain is very smart. It does whatever it can to avoid pain, and so this is one way that it tries to compensate. The problem with that compensatory pattern is that over time it tends to develop a lot of muscle tightness, particularly in some of the hip flexors that pull you over, and so it can be very hard to kind of get out of that pattern. So because you've got not just the spinal stenosis working against you, meaning that when you straighten up, that narrowing gets a little worse in your spine, but now you've developed a lot of muscle tightness that's working against you as well, and you're also going to be at risk for developing hip problems and hip arthritis. So it is really it's a tough challenge to deal with, and it's actually that's absolutely a situation where where we really recommend aggressive physical therapy or manual therapy. So sometimes also just trying to, whenever you can treat the underlying problem, that's ideal. So so if it's spinal stenosis or joint pain, whatever we can do to treat that underlying issue and get the pain under control, and that might take the form of perhaps an epidural steroid injection or a platelet-based regenerative medicine procedure. We get your symptoms better, so you're not having the pain. So the primary problem isn't there, at least to the same degree, and then we get you into therapy and then really work on more aggressive stretching and strengthening to try to get you more upright. So.
Yeah, and sometimes if it's more of a mid or upper back issue, that's something that can be really hard to deal with because you're so used to being hunched over, and it's hard to open up your chest. So for those people, usually get some aggressive physical therapy or chiropractic where they can mobilize the segments of your spine to help them move more freely so that you can stand up straight. That could be beneficial.
Yeah. Okay. A bone marrow injection really helped ease back pain. Approximately how long do these improvements last? So that is a tough question to answer. Certainly, we have patients, where we've done, and I think you're referring to a injection in the disc with bone marrow, and so it's actually a bone marrow concentrate of cells. Particularly mesenchymal stem cells, which are integral in terms of tissue regeneration and healing. And so, Dr. Scollon-Grieve and I are part of the Regenix network, and one of the reasons why we really love this network is because they are and we are obsessed with data collection and data gathering and monitoring. So, every patient who has a procedure with us is put in a database, and so these patients are tracked for years. And so we have data now going on 4 years, looking at patients who've had PRP injections or bone marrow injections, like you're referring to, into the disc. And so the nice thing about these treatments is they tend to last. And so there are several good studies out there which show that those patients who do respond are maintaining that improvement at 1, 2, and even 5 years out. So, those who do respond usually do maintain. I will tell you though that it's hard to say beyond 5 years, where you're going to be, just because these are, relatively newer treatments that we've been using with some really good success. So. What do you think, Dr. Scollon-Grieve? What's your?
Yeah, I completely agree. It's just too soon to tell, and everybody's different. So, you can't make any promises saying it will cure you forever, but the results are certainly good and optimistic, and there is, minimal downside to injecting your own products into your back rather than getting cut open.
Yeah, and I think as Dr. Scollon-Grieve was saying that that it is difficult. There's no guarantees, particularly when it comes to the spine. I mean, this is in medicine in general, but particularly when it comes to the spine. And so, I think that our approach, we were very realistic with patients. We're big believers in education, talking to them about the option, and ultimately, the patient is the decision maker. But when you're talking about these forms of treatments, be it a traditional steroid-based injection or regenerative medicine treatment, there's no treatment that's 100%. In fact, there's no treatment that's 95%. So I think we try to be very realistic when we set up expectations. And so, 60%, 70%, when you're dealing with the spine, these are actually very good percentages. But, if someone's telling you, guaranteeing results and telling you 99% chances is going to work, particularly when you're dealing with the spine, I think you need to be very, very cautious. So. All right, I think we're kind of winding down here, running out of time. Looks like one last question. How many regenerative procedures do you do a month? You want to go first?
It really varies. I would say an average of maybe 5 a week, so maybe 20 a month. Really depends on the time of year. Sometimes it's much more busy, and sometimes it's not.
Yeah.
Some of the procedures take long, so we can only do one patient a day. We have to process everything in the lab, and only one patient's blood product can be processed in the lab. So, and that can take some of them up to 4 hours to process the blood. So that's the limiting factor in how many we can do a day.
Yeah, I agree. I think I'm, sort of in the same boat. I will say that more and more patients now are reaching out and asking about these sorts of procedures, and there's way more interest. And I think that patients now, the word is getting out that long-term steroid use is not ideal, and that there are some other options out there. And as that word gets out, I've got more and more patients who are coming in the office actually asking for these procedures and proactively doing so. So, it's I think that every year, you see the number of these procedures going up, and I think it's really good. I know, while we do a lot of different things in our office to help patients with pain and back pain in particular, personally, I'm really excited by the regenerative medicine procedures the most, and those are the ones that I think we're most passionate about, just because we see some pretty amazing results, and not only that, but that we're doing it in a very natural type manner. So, all right. I think it's just about 1:30. I think we probably need to kind of wind down, but I know personally, I thank everyone who tuned in, and thanks for listening to us, and thanks for all the great questions. Certainly, if you have any other questions, you can absolutely reach out and give our office a call, and we're happy to help in any way we can.
Yeah, thank you for putting up with our technical difficulties. And I think you could certainly email the marketing department at Premier if you have any specific questions, and they can always pass them along to us.
Yeah. All right, good. All right, well, thank you all. We'll see you soon.
Thank you.